Good morning, Vijay.
Good morning, madam. Good morning.
ఏం చెప్పేది టాక్ ఎవరు
సార్ నేను జయకుమార్ సార్ రాజం
హాయ్ హాయ్
సార్ గుడ్ మార్నింగ్ సార్.
సరే సరే ఓకే. శ్రీకాంత్ ఉన్నాడా?
శ్రీకాంత్ వచ్చినట్లేదు సార్.
ఫోన్ చేసి స్టార్ట్ చేయమను, టైం అయిపోయిందిగా.
స్టార్ట్ చేస్తాను సార్.
ఒకసారి శ్రీకాంత్ ఫోన్ చేయి.
మోహన్ సార్ గుడ్ మార్నింగ్ సార్.
కిరణ్ శ్రీకాంత్ వస్తాడా?
శ్రీకాంత్ మేబీ జాయిన్ అవ్వలేనేమో అని మెసేజ్ పెట్టినట్టున్నాడు గ్రూప్ లో.
కాల్ చేయమంటున్నారు సార్.
ఒకసారి నేను చేస్తాను.
అనురాధ స్టార్ట్ చేద్దామా? 8:10 అయిపోతుంది. 8:10 అయిపోయింది, స్టార్ట్ చేస్తావా విజయ్?
అలాగే సార్.
కిరణ్ ఉన్నారు కదా సార్, రాజం కిరణ్ మీరు స్టార్ట్. కిరణ్ రాజం కిరణ్
ఉన్నారా?
ఉన్నారు.
కిరణ్
ఫోన్ మాట్లాడు
సార్.
కిరణ్
ఫోన్ ట్రై చేశాను సార్, తను అవ్వట్లేదు సార్. యాక్చువల్ జర్నీ
స్టార్ట్ చేయి కిరణ్.
ఓకే. విజిట్ స్టార్ట్ చేసేద్దామా?
Good morning, my dear sir and madam. Today my topic is anesthetic management in pregnant patient with myasthenia gravis. Myasthenia gravis is autoimmune disorder with a peak onset among of reproductive age. The normal physiological changes of pregnancy can lead to deterioration in the pre-existing associated neurology. For example, exacerbation of the existing respiratory compromise. A thorough assessment and careful multidisciplinary planning are necessary to provide a safe peripartum care.
కిరణ్ బషీర్ నిద్రపోతున్నాడు, అవి మైక్ ఆఫ్ చేయవా కిరణ్? నువ్వు కోహోస్ట్ కదా.
Incidence and prevalence. Myasthenia gravis is an autoimmune disease. It's typified by the weakness and fatigability of the skeletal muscle, and the incidence is approximately 50 to 140 per million, with a prevalence of 1 in 10,000 to 50,000. Myasthenia gravis affects women twice as often men. It commonly affects women in second and third decade of life. The clinical severity of myasthenia gravis ranges from a pure ocular muscle involvement, ocular myasthenia gravis, to a generalized muscular weakness, generalized myasthenia gravis. Generalized myasthenia gravis further graded into mild, moderate, severe, depending upon the degree of weakness. Myasthenia gravis is a classification is a Osner myasthenia gravis staging. Later, it is divided into myasthenia gravis stage foundation for America. This is five stages. Is in stage one only ocular involvement, and stage two is generalized and mild muscle weakness. In that 2A, 2B are there. In 2A, there is predominantly affecting the limbs and axial muscles, where 2B predominantly bulbar symptoms and respiratory weakness. In type 3, there is a generalized moderate weakness. So here also same 3A means predominantly affecting the limb and axial muscles. 3B is bulbar symptoms and respiratory muscles. 4 is generalized, stage 4 is the generalized severe weakness. Here 4A is predominantly limb and axial muscles. 4B is the predominantly bulbar symptoms and respiratory weakness. And stage 5 is the tracheal intubation and mechanical ventilation. Approximately 80 to 90% of the generalized myasthenia gravis patients and 50 to 70% of the ocular myasthenia gravis patients have acetylcholine receptor antibodies in their serum. Other antibodies which are commonly seen in myasthenic patients include anti-muscarinic, anti-muscle specific kinase antibodies, which are seen in about 40% of AChR antibody negative myasthenic gravis patients. And other antibodies are the against lipoprotein receptor related protein 4. And approximately 10% of patients with myasthenia gravis have thymoma. Effects of myasthenia gravis and vice versa, pregnancy vice versa. It affects most commonly childbearing age. It is not uncommon encounter a pregnancy complicated by myasthenia gravis. The effects of pregnancy and the severity of myasthenia are variable. In one study, while 30% of population did not show any change, and 29% of reported some improvement, and 49% reported a worsening of myasthenic symptoms during pregnancy. Worsening of myasthenic symptoms was usually in the first trimester and the first month following delivery, while the improvement of myasthenic symptoms were reported during second and third trimesters, likely related to the pregnancy-induced immunosuppression which occur in these trimesters. Main causes of exacerbations include hypoventilation due to weakness of respiratory muscles and elevation of diaphragm during pregnancy, and puerperal infections, drugs, stress of labor, delivery, or the exacerbating conditions. In general, myasthenia does not affect pregnancy to large extent. There is no increased risk of low birth weight or spontaneous abortion or prematurity, although an increased risk of premature rupture of membranes does exist in the myasthenic women, reason which is not very clear. The pathophysiology and diagnosis. Myasthenia gravis is characterized by autoantibody destruction of nicotinic acetylcholine receptors in the postsynaptic junction, leading to reduced transmission of nerve impulses at the motor end plate. Myasthenia is characterized by fatigable weakness of voluntary muscles due to reduced acetylcholine release with repeated stimulation. Difficulty with mastication and dysphagia indicate the weakness of the pharyngeal and laryngeal muscles described as a bulbar involvement. Here is the diagram shows normal nerve and myasthenia patient nerve and motor and neuromuscular junction. Acetylcholine is releases in the normal nerve. Here more number of receptors and acetylcholine is attached, and the more transmission of nerve impulses takes place. But in myasthenia gravis, There is a acetylcholine is there, but antibody is present at attached to the antibody attached to the acetylcholine receptor. So the leads to reduced transmission of nerve impulse. Myasthenia gravis is diagnosed using anticholinesterase test, where strength improves with administration of edrophonium, that is tensilon test. The electromyography demonstrate decreasing response to repeated stimulation of peripheral motor nerves. Acetylcholine receptors antibodies are found in 85% of patients with generalized myasthenia and 50 to 60% of ocular MZ. Myasthenia often associated with other autoimmune diseases, particularly thyroid disease, rheumatoid arthritis, SLE. So these should be screened for these diseases. Treatment: anticholinestases, pyridostigmine, which is the increases the acetylcholine available at the neuromuscular junction, and immunosuppression therapy, corticosteroids with the azathioprine, cyclosporin, and mycophenolate. The dose of anticholinesterase may need increased during pregnancy due to larger plasma volume and greater renal elimination. And hyperemesis of pregnancy may affect the drug absorption, and parenteral may be required to improve the reliability of the drug delivery. The systemic steroids are safe to continue during pregnancy, whereas azathioprine and mycophenolate are not recommended due to potential risk of teratogenicity. The involvement of neurologists with special interest in the myasthenia gravis is advised when planning pregnancy in order to evaluate the risks and benefits of continuing each medication. Anticholinesterase is mainstay treatment in myasthenia. The dose is 30 milligrams at 8th interval time and frequency. Dose is increased up to 750 milligrams per day. Higher doses can produce a paradoxical increase in weakness. Drug may lose its efficacy over a period of time. The myasthenic side effects of these drugs can be controlled with the use of anticholinergic drugs like propanthyline and mebivirine. Several studies shows that pyridostigmine is safe and it crosses the placenta freely and good concentration amniotic fluid. Dose and administration need to be changed during pregnancy, and it may range from small dose 30 milligrams administered on as when required basis, frequent administration of large doses. Usually intravenous dose administrations may cause uterine contractions. That is given in some Indian pharmacology uh, uh, article. Actually, this I don't have any experience in myasthenia gravis, and but regarding intravenous administration of acetylcholine inhibitors. Steroids are the continued by the most commonly used immunosuppressive drugs in the myasthenia, and slightly increased risk of cleft palate. Other side effects are the premature delivery and premature rupture of membranes, Cushing-Guard appearance, weight gain, and withdrawal may lead to the exacerbation. This slide shows doses regarding steroid. It may usually start with low dose 5 milligrams prednisolone and increase by 5 to 7 milligrams. This azathioprine actually is not using, but with this azathioprine there is increased risk of IUGR and increased rate of prematurity and low birth weight. But here no shows any increased risk of malformations. But this drug is not used in, risky drug, considered risky drug as USA. Rituximab is the other drug frequently used in the myasthenia gravis in severe and muscle specific sinus antibody positive myasthenia gravis. it also crosses the placenta, and the drug is not has been reported to major fetal side effects, but causes decreased B cell count. However, recording the use of this drug pregnancy is still limited, and frequent ultrasonography fetal well-being is recommended. And if the symptoms of deteriorate, and it is important to distinguish between the myasthenia crisis from the undertreatment and a cholinergic crisis due to overtreatment with acetylcholinesterase inhibitors, as management is approach differ. The labor and sleep deprivation, infection, surgery, emotional stress, and pain are all are precipitants of myasthenia crisis. The intravenous immunoglobulin and plasmapheresis may be considered in myasthenic crisis. There is an association of myasthenia with the thymoma. Thymectomy improve the clinical outcome in myasthenia gravis patients, reducing the severity of symptoms and frequency and a need for hospitalization. In patients with myasthenia gravis, it is important to avoid drugs that exacerbate the weakness at the neuromuscular junction. Next slide as shows. Drugs may worsen the myasthenia gravis. So, neuromuscular blocking drugs, aminoglycosides, fluoroquinolones, vancomycin, beta blocking drugs such as propranolol, labetalol, metoprolol, antiarrhythmics like the procainamide, quinidine, magnesium, chloroquine, hydroxychloroquine, quinine, penicillamine, botulinum toxin, monoclonal antibodies such as nivolumab and pembrolizumab. Other drugs, but usually well tolerated, but may worsen the myasthenia, are inhalation local and local anesthetic drugs such as isoflurane, halothane, bupivacaine, lidocaine, procaine, antibiotics like ritonavir and tetracycline, macrolide antibiotics, anti-epileptics such as carbamazepine, gabapentin, phenytoin, phenobarbital. Glucocorticoids are started in high doses. Antipsychotics like lithium, phenothiazines, butorphenols, calcium channel blockers are also tolerated but may worsen the myasthenia. These are the other drugs we should avoid in myasthenia gravis. Neonatal consideration and maternal acetylcholine receptor antibodies, they cross the placenta, induce the transient muscle weakness in 10 to 20% of neonates born to the myasthenic mothers. Thus, all infant born to the women with myasthenia gravis should be observed carefully any signs of muscle weakness, including bulbar and respiratory muscles. Although reported reversing within 3 weeks, the syndrome has been last for as long as 4 months. There is no correlation between the occurrence of neonatal myasthenia gravis and maternal antibody titers, as well as severity of the mother myasthenia gravis in the mother. Thus, it is impossible to predict the likelihood of neonatal myasthenia in index women. Treatment usually include administration of cholinesterase inhibitor drugs, and rarely ventilator support. Even small volume plasma exchange may be required. These other complications are include pulmonary rare complications, but pulmonary aplasia and orthoxeropsis multiple congenita. The former is pulmonary aplasia is due to the lack of diaphragmatic movement, and orthoxeropsis multiple congenita is due to the passive transfer of acetylcholine antibodies to unit. Decreased limb movements due to passive transfer of maternal ACH receptors to units. There is a correlation between the antibodies and the occurrence of the AMC in the units. Polyhydramnios also result in mother, and transient hyperbilirubinemia is another complication in units. And regarding breastfeeding, steroids and anticholinesterase inhibitors are safe in breastfeeding, but other drugs such as azathioprine, mycophenolate, cyclosporine, cyclophosphamide are excreted in the breast milk, and breastfeeding should be avoided in these patients. Same. And so disease course in the pregnancy, it is clinical course of myasthenia gravis is difficult to predict, but it improves in 1/3, remains same in the 1/3, and worsen in 1/3 of patients. So during in pregnancy, the physiological changes can cause decrease the lower esophageal sphincter tone, which can increase the risk of gastroesophageal reflux. Patients with myasthenia gravis and bulbar involvement are particularly risk of subsequent aspiration. So they are less able to clear the secretions and protect their airway. Slide shows difference between the cholinergic and myasthenia gravis. In myasthenia, there is nicotinic receptors are affected, leads to flaccid weakness and no fasciculations. Here a signs is eyes ptosis, normal pupil. Autonomic symptoms may be present but not a prominent feature. Whereas in cholinergic crisis, here also same flaccid weakness and fasciculations. Cholinergic crisis is both nicotinic and muscarinic toxicity from the excess acetylcholinease inhibitors. The eye signs, there is no ptosis in the cholinergic crisis, the small pupil in the eyes. Whereas muscarinic toxicity here is cardiovascular, bradycardia, hypotension, respiratory rhinorrhea, bronchoria, bronchospasm, cough, and severe respiratory distress, gastrointestinal hypersalivation, nausea, vomiting, abdominal pain, diarrhea and fecal incontinence, genitourinary incontinence. We know that myasthenia is due to the disease exacerbation, where the patient getting more muscle weakness and distress, and signs impending crisis and difficulty swallowing, difficulty of bringing out of secretions, and use of accessory muscles. The patient is has a normal respiratory drive but manifest with the small respiratory tidal volumes and rapid breathing if they are awake and not intubated. Usually myasthenia gravis crisis is precipitated by the infection, sepsis, anxiety, stress, and surgery. So additional dose of anticholinesterase is the treatment. If no improvement is seen, plasmapheresis or immunotherapy should be initiated. We know that cholinergic crisis is due to excess cholinergic drugs, usually identified the sludge, and it occurs usually rare but may seen after administration of reversal of neuromuscular blocking agents. Treatment is immediate cessation of anticholinesterase drugs. If required, intubate the patient. This is a slide shows what are the risk factors for post-operative pulmonary complications. Post-operative, pre-operative vital capacity is less than 2 to 2.9 liters. Duration of myasthenia gravis more than 6 years. Dose of pyridostigmine is 750 milligrams per day. History of pulmonary disease. Pre-operative bulbar symptoms. History of myasthenia crisis. Pre-operative blood loss more than 1 liter. And serum acetylcholine receptor antibodies more than 100 nanometers per liter. It's more pronounced detrimental response to repetitive stimulation. So it is very important to differentiate between the myasthenia crisis and the cholinergic crisis. It shows both the symptoms are similar almost, but however, the heterophonium test will help in differentiate between the two conditions. While it will result in immediate improvement or no change in myasthenia crisis, while cholinergic crisis will worsen. In pregnancy, intercostal muscle weakness in myasthenia gravis can exacerbate, reduce the functional residual capacity and residual volume that are normal anatomical changes in pregnancy, which could precipitate respiratory failure. However, this is rare. And uterus is consists of smooth muscle, and it is not affected by myasthenia gravis. Therefore, first stage of labor usually is not affected by myasthenia, and skeletal muscle contributes to pushing in second stage of labor. Therefore, assisted delivery may be required for the prevent fatigue. Anesthetic considerations. There are three main areas of consideration of anesthetic management in patients with myasthenia. Respiratory compromise, bulbar involvement, autonomic dysfunction. Respiratory compromise. Here the pulmonary function test demonstrate reduced forced vital capacity. So supine position may worsen respiratory compromise, and frequent monitoring is required for a perioperative assess for perioperative deterioration. In case of bulbar involvement, intubation and ventilation may be required for surgery. So careful assess risk and benefits of neuraxial and general anesthesia. So general anesthesia may increase the risk of aspiration if not secured, while neuraxial anesthesia risk decompensation of respiratory reserve with paralysis of axillary muscles. And for patients undergoing general anesthesia, there should be careful assessment of suitability for extubation. A close post-operative monitoring is vital to allow the prompt recognition of respiratory compromise following neuraxial and general anesthesia. Post-operative ventilator support is maybe needed, required for the intensive care unit and a high dependency unit. In autonomic dysfunction, emptying, increased risk of aspiration, reduced variability in the heart rate and deep inspiration and on standing. So cardiovascular instability, severe hypertension from laryngoscopy and surgical stimulus. So profound hypertension from the positive pressure ventilation and neuraxial and general anesthesia. So hypovolemia is poorly tolerated. So increased sensitivity to direct acting sympathomimetics, impaired respiratory reflexes leading to hyperventilation. So how will you manage patient? So initially assess the patient assessment. Patient should be referred to the high obstetric anesthetic clinic with a physical assessment, a detailed history and documentation of pre-existing neurological deficits, and is clinically how it is clinical course of disease is stable or frequent or severe exacerbations are there, any respiratory compromise or any history of ventilator support, any bulbar involvement is there, any autonomic dysfunction signs are there, ability to lie supine should be observed. Other tests are blood test, full blood count, electrolyte and renal function, thyroid test and autoimmune screen, and electrocardiogram, pulmonary function test. After careful assessment, a multidisciplinary team with including anesthetic, obstetric, neurology, and intensive care unit input for the management of the plan should be formulated, agreed with the patient. These are the drugs and mechanism of actions. We should avoid these drugs and their mechanism of action. Okay. In case of labor, myasthenia alone does not mandate cesarean delivery, and optimize pain control, avoid prolonged labor to reduce the weakness from the fatigue, avoid exertion and avoid stress, which may trigger myasthenic crisis. So avoid systemic opioids and patient control analgesia if there is significant pre-existing respiratory insufficiency. Epidural anesthesia is recommended for the labor. In patients with respiratory compromise, cautious titration of epidural analgesia, aiming for sensory level of T10 and using a weak solution of local anesthetic combined with opioid 0.0625 of levo or bupivacaine plus 2 mg per ml fentanyl or 0.4% per ml fentanyl. Direct observation with continuous monitoring is advised. A continuous consider assisted delivery to reduce the fatigue during second stage of labor. Anticholinesterase and steroid therapy must be continued throughout the pregnancy. Parenteral root dose may be required. Anesthesia for cesarean delivery. We will pre-medicate the patient. H2 receptor antagonist, H2 antagonist for antacid prophylaxis. Metoclopramide to promote the gastric emptying. Avoid benzodiazepines and systemic opioids due to risk of respiratory depression. Optimize the fluid status. Hypovolemia is poorly tolerated in these patients with autonomic dysfunction, and iotocaval compression on lying on supine worsen cardiovascular instability. Ensure left lateral uterine displacement and avoid hypovolemia. Invasive monitoring is required for the patients with autonomic dysfunction. Both the neuraxial and general anesthesia are safely administered in patients with myasthenia, but neuraxial anesthesia allows for earlier return to oral intake of medications. Patients with bulbar involvement and respiratory compromise may not tolerate a mid-thoracic level of neural anesthesia due to paralysis of accessory muscles, but may also have an increased risk of aspiration associated with general anesthesia. So, aim to achieve adequate block while avoiding excessive cardiovascular instability from sympathetic blockade and respiratory impairment from paralyzing the intercostal muscles is too high. So adding small dose of opioid to local anesthetic reduces the total dose of local anesthetic required due to synergistic effect, improves the block quality, reduces systemic opioid requirement postoperatively. Epidural anesthesia allows for careful titration and of local anesthetic using incremental bolus, which lead to the cardiovascular stability and avoidance of excessive high block. Patients with autonomic dysfunction and a mild respiratory muscle involved may also benefit from the epidural technique. The epidural catheter can also be administered local anesthesia for pain control postoperatively. Spinal anesthesia is a faster, more reliable than epidural anesthesia. It minimizes the total dose of local anesthetic administered, which may be beneficial as high serum levels of local anesthetic theoretically potentiate the neuromuscular blockade. However, spinals are associated with more cardiovascular instability and potentially higher block as a result of speed of onset and inability to titrate the effect. Combined spinal epidural anesthesia is with the low dose spinal component has advantages, both the spinal and epidural. A reliable surgical anesthesia can be rapidly attained while maintaining the relative cardiovascular respiratory stability. General anesthesia may be required for securing the airway, providing ventilator support if there is a significant respiratory insufficiency. It is also an option in patients contraindications to neuraxial anesthesia. There is overall increased sensitivity to neuromuscular blocking drugs in patients with myasthenia, which greatly reduces the actual required dose. So importantly, closely monitor the depth of neuromuscular blockade. Saxamithen is contraindicated in the myasthenia gravis patients. The inhalation agents contain muscle relaxing properties, therefore dose is kept to minimum. Depth of anesthesia monitoring may be a useful adjuvant in the view of increased risk of awareness in the obstetric patients. A short-acting intravenous opioids can be administered in patients with myasthenia gravis. Use of reversal is controversial. The options here are the spontaneous recovery from the atracurium, administer sugammadex to reverse the rocorium, administer neostigmine to reverse the atracurium and rocorium. In myasthenia gravis, high dose of neostigmine risks the precipitating cholinergic crisis, whereas generalized muscle weakness may be difficult to distinguish from the myasthenic crisis. Slide sugammadex with neostigmine. Sugammadex is a cyclodextrin medication that is usually reverse the steroidal reversal this steroidal neuromuscular blocking agents, acts by the encapsulating the neuromuscular blocking agents in a water soluble complex, unlike an neostigmine, which act competitively displacing the neuromuscular blocking from the end plate. Neostigmine should be used only when the at least of top 1 out of 4 is present, whereas sugammadex can be used in moderate to severe block. There are few reports of failure of reversal of neuromuscular block with sugammadex. In that case, a small dose of neostigmine has shown to increase complete reversal can take place. Sugammadex can be considered as a safe, reliable, efficient reversal agent in the patient with myasthenia gravis. Intravenous administration of oxytocin can worsen the pre-existing hypotension from autonomic dysfunction related myasthenia gravis. So, and the vasodilatory effects of anesthesia. Therefore, it should be administered very cautiously in divided doses or as an infusion. Postoperative care, ideally, patient should be cared in the intensive care unit and high dependency unit. assess the respiratory function using respirometry measurements, allow early detection of clinical deterioration. Respiratory support should be provided with chest physiotherapy, appropriate positioning, assistance with secretion clearance, and non-invasive and invasive ventilation if required. A cardiovascular monitoring with optimization of fluid status need to continue in the postoperative period. Oral medications, particularly anticholinergics, should be recommended as soon as possible. In summary, the normal physiological changes in pregnancy can exacerbate the myasthenia gravis. Respiratory compromise like bulbar and autonomic dysfunctions are common, and careful assessment and severity detailed documentation is required. Neuroaxial anesthesia can be safely administered in patients with myasthenia gravis. The risk and benefits of general anesthesia, neuroaxial anesthesia should be considered for patients with myasthenia gravis, particularly those with the respiratory compromise. The anesthetist must weigh up the risks and benefits of individual basis in a patient with myasthenia gravis so that patient can make informed choice during labor and delivery. Thank you. Thank you very much.
Thank you, Vijay. Nice presentation.
కానీ
Thank you.
చాలా ఉంది, నేను అనుకోలేదు ఇంత ఉంటుంది.
సార్ యాక్చువల్ గా మేము ముందు మైస్థీనియా గ్రేవిస్ చెప్దాం అనుకున్నాం సార్. ఈ లోపు క్రిటికల్ కేర్ టాపిక్ కూడా అదే సార్, రెండు కంబైన్డ్ అయిపోయింది. అందుకు మళ్ళీ కొంచెం ఎలాబరేట్ చేస్తాం సార్.
అదే బాగుంది, బట్ ఏంటి ఇంత తక్కువ మంది ఉన్నారేంటి? సరే, ఓన్లీ 5-10 people, 10 people కూడా లేరు
సార్. థైమక్టమీ కేసు చేసేటప్పుడు మైస్థీనియా గ్రేవిస్ పేషెంట్ కి కన్సర్న్స్ ఏముంటాయి సార్? యాక్చువల్ మేమైతే ఎప్పుడు చూడలేదు.
We have done థైమెక్టమీ ఫర్ మైస్థీనియా కేసెస్. మా దగ్గర మా ఓల్డ్ ఎంప్లాయీ ఉండేవాళ్ళు. సో వాళ్ళకే కాదు, పివి సత్యనారాయణ చాలా మంది చేసేవాడు. చాలా మంది అంటే కొంతమందికి. సో వి యూస్ టు ఆప్టిమైజ్ ద పేషెంట్ ఫస్ట్. క్లినికల్ గా న్యూరాలజిస్ట్ కన్సల్ట్ తీసుకొని వాళ్ళు ఆప్టిమైజ్ చేసుకొని దెన్ వీ యూస్ టు పోస్ట్ పోత్, బికాస్ అదర్వైజ్ పోస్ట్ థైమెక్టమీ అగైన్ దే గో ఇంటు క్రైసిస్ అని చెప్పేసి నేను ఐ రిమెంబర్ దట్ వే, బికాస్ లాంగ్ టైమ్ బ్యాక్. I don't know if any seniors like Rani madam or Anuradha can speak more.
Sir, that first post-op day we are continue ventilation, sir. After neurophysian consultation only plan for extubation, what I remember.
Hello.
Hello, madam.
Oh, hi. Yeah, post-thymectomy, Anuradha చెప్పినట్టు అలా 1 day ventilate చేసి extubate చేసాము. But patient went into like a respiratory failure again. He needed re-intubation, extubation, మళ్ళీ failure, extubation. So ended up on tracheostomy. And slowly muscle power improve చేయించి like breathing exercises, అది ఫిజియో ఇవన్నీ చేయించి అలాంగ్ విత్ మెడికేషన్ ఇవన్నీ చేస్తూ గ్రాడ్యువల్ గా వీ కుడ్ వీన్ హిమ్ ఆఫ్ కంప్లీట్లీ. ఇట్ టుక్ టైమ్. అనురాధ, మోహన్ సార్, ఇఫ్ యూ రిమెంబర్ దట్ ముస్లిం పేషెంట్ ఉండేవారు కదా థైమెక్టమీ తర్వాత, హీ వెంట్ ఆన్ టు వెంటిలేటర్ అండ్ ట్రెకియోస్టమీ. సో ఐ రిమెంబర్ వెరీ వెల్, సిటీలో ఉంది. అండ్ that patient actually, before having thymectomy, he had FES surgery done. He was on medication, but he didn't tell the anesthetist in PAC that he has this problem. As usual, normal GA ఇచ్చేసి చేసేసారు. పోస్ట్-ఆప్ లైక్ ట్రిగర్స్ ఉన్నాయి, ఎఫర్ట్స్ ఉన్నాయి అనేసి రివర్సల్ ఇచ్చి ఎక్స్ట్యూబేట్ చేసేసారు. ఎక్స్ట్యూబేషన్ టైం రివర్సల్ ఇస్తాం కాబట్టి బ్రీఫ్లీ he improved, but then again in post-op SICU low, like he deteriorated, he couldn't maintain airway, like he needed re-intubation again. So appudu why, what happened ani like again like our family to maatladinappudu edo medicines veskuntadu, we also don't know ani wife edo techiste chuste avi pyridostigmine annamata. Then we realized, oh my god, this patient has this, what చెప్పను కూడా చెప్పలేదు అసలు, and he has normal usual GA. So that patient afterwards, he went for all investigations. He had thymectomy. Appudu kuda he had difficult weaning and needed tracheostomy. So we have experience of myasthenia gravis with 2-3 patients, difficult weaning, difficult reintubations and extubations like that, and prolonged weaning. So in crisis they came. So we have seen a few patients. Thank you.
Thank you.
Madam, any difficult intubation, madam, during thymectomy in thymectomy patient?
I didn't do the intubation, but I think they usually have CT scan, everything done and assessed for airway and everything. So like at laryngeal level, I don't think they'll have any problem. So I don't think, or I don't remember if they had any difficult intubation. Maybe Anuradha or Mohansa did the intubation, I'm not sure.
No difficult intubation that time. Only I remember 2 cases only.
కిరణ్ ఎప్పుడు మైస్థీనియా గ్రేవిస్ కి డిఫికల్ట్ ఇంట్యూబేషన్ ఎప్పుడు ఫీల్ అవ్వలేదు, తెలియలేదు, నాకు తెలియదు.
Okay, sir. Thank you, sir.
Because it's the swelling in the anterior mediastinum, not at the higher level. So usually you don't encounter difficult intubation. Like otherwise, if you have any other features or unanticipated difficult intubation, anterior larynx like that, but per se with thymus, I don't think you'll have difficult intubation.
Okay, madam. Vijay, one more question. If the patient needs emergency surgery and also patient is in crisis, how you are going to proceed?
Plasmapheresis. So it removes the almost most of the antibodies from the patient. So for a short-lived time, patient will be unasymptomatic. Usually plasmapheresis and may lead to usually for volume depletion. So you have to careful about volume status before any further surgery.
ఇందాక వచ్చినప్పుడు లేడు. ఒకసారి మళ్ళీ రిపీట్ చేయొచ్చు, ఏంటంటే వాల్యూమ్ స్టేటస్.
Usually the for emergency myasthenia crisis, usually the treatment is a dose of anticholesterol medication. Higher the dose of medication, higher the dose of pyridostigmine or the plasmapheresis. If you use the plasmapheresis in any patient, usually volume will be lost. So fluid status we have to maintain in that patient before going to any further surgery.
Okay, Vijay, thank you. One more question, Vijay. Hello, Vijay.
Okay.
If generally we will avoid general anesthesia in myasthenia patients, as but if at all we give general anesthesia, how you are going to extubate? What are the any criteria? How you are going to extubate the patient? When you are going to extubate, generally there will be difficulty in extubation. No? That's why.
Usually the TOF monitoring is very important while extubating. So TOF train of ratio is more than 0.9, then only we have to give this neostigmine. And if its train of monitor is not there, then persistent head lifting more than 23 seconds, like more than 30 seconds, we can extubate the patient. This is the one.
30 సెకండ్ ఏం లిఫ్ట్ చేయాలి?
Head lift, sir. Head lift.
30 seconds మనమే చేయలేమేమో.
Actually,
But-
it is
Difficult to extubation, no? So that's why we have to wait for 1 day and after that plan for extubation.
అలా చేయకూడదు అంటారా యాక్చువల్ గా. యూ ఆర్ నాట్ సపోజ్ టు వెయిట్ ఆన్ వెంటిలేటర్ ఫర్ 1 day. దట్స్ మోర్
Not
యాక్చువల్లీ.
ventilator, sir. Optimize చేసుకోవాలి post op. Immediately we can't extubate. No, slowly wean off and we extubate.
అదే వాట్ ఈస్ ద క్రైటీరియా అని అడుగుతున్నాడు.
a criteria is a patient is when fully awake and his tidal volume is more than 5 ml per kg and respiratory rate should be less than 30 per minute and the top ratio is more than 0.9. Head lifting is more than 30 seconds. Kiran,
కిరణ్ అంతేనా ఇంకేమన్నా ఉందా?
అంతే సార్ యాక్చువల్. అట్ సేమ్ టైం బల్బార్ వీక్నెస్ ఏమైనా ఉందా అంటే రెసిడ్యూల్ గా ఉండేది బల్బార్ వీక్నెస్ ఉంటుంది సార్. దేర్ కెన్ బి ఛాన్సెస్ ఆఫ్ ఆస్పిరేషన్.
more than, sorry sir, more than 5 seconds.
5 seconds. That's not more.
Yeah,
Not
usual criteria for patient head lift
Extubation.
is 5 seconds only. We
5
don't see
seconds.
for 20 seconds. 5 seconds only kada. Indulo 20 ante even like 4 times normal people anta expect cheyalem kada.
More than 5 seconds. Sir.
Yeah.
more than 5 seconds.
And also
Very
you
tricky.
can see like criteria for intubation laga criteria for extubation kuda maximal inspiratory pressure, expiratory pressure avi chudama. I think we can do that also.
Yes,
Yeah.
madam. We can.
Hello,
Hello,
good
sir.
morning.
Good morning,
Ah.
sir.
What happens if you give more than the calculated dose of neostigmin during reversal?
Cholinergic crisis, sir.
Dual block, no? Presynaptic potentiation.
Phase 2 block.
Hello,
Hello, sir. Hello, madam.
Vijay, like Kiran asked about emergency surgery in crisis, right? So in
Yes, ma'am.
crisis ఉన్నప్పుడు anyway like you have high risk of failed extubation weaning the ventilator, so counseling is very important. This patient may need ventilation post operatively, ivanni తీసుకోవాలి, consent తీసుకోవాలి. And as you all mentioned, plasmapheresis cheste you can start before surgery itself, like and continue into the post-op period. Cycles avval kada, you just finish in one cycle. You have to continue with the cycles.
Okay.
But it may not work immediately, right? So you have to do 3 to 5 cycles avvali. So
Okay.
post-op ventilation is important. Okay.
Okay.
So most of the times, if you have to do in crisis time, you will end up on ventilator only.
Is there any role of steroids in thymectomy?
Thymectomy. No role, sir.
Because myasthenia gravis and thymomas are usually associated with autoimmune disorders. No?
Yes, sir.
So if patient is on preoperatively on steroids, you have to supplement steroids, I think.
Patient if he is on steroids, which I have to supplement. You're asking thymoma.
If the patient is on steroids in thymoma patient, we have to supplement. Otherwise, no need to supplement.
Okay, thank you.
One more question, sir. Actually, generally we use neostigmin for almost all general anesthesia patients at the time of reversal.
పీరియడ్స్ నుంచి ఇంకోసారి మళ్ళీ రిపీట్ చేయవా పాయింట్?
Sir, if the myasthenia gravis patient, the patient is on steroid treatment, we have to continue the steroids, sir. If the patient is not on any steroid treatment, no need to continue.
థ్యాంక్ యూ.
What type of neurovascular agents are you using in a
Cisatracurine.
myasthenia
So,
patient?
you are talking something else. Continue that.
Cisatracurine, madam. Atracurium, cisatracurium. Short-acting neuromuscular blocking agents.
Why you are more interested in plasmapheresis?
More interested means if the patient is not, whenever the pyridostigmine and other drugs are not useful and not benefiting, then only we will go with plasmapheresis and immunomodulating drugs.
By plasmapheresis means we have to remove some
You have to remove the
To
antibodies.
remove the antibodies.
Remove the antibodies for 2 sessions, so it
Mm.
reduce the crisis.
Okay.
Sir, one more question. Generally, after giving general anesthesia, we generally use neostigmine for reversal of muscle relaxant. But what is the difference between neostigmine and pyridostigmine, sir? రమణ ప్రసాద్ సార్ మీరైతే చెప్పగలుగుతారు ఇది. సో నాకైతే ఈ డౌట్ ఎప్పటి నుంచో ఉండిపోయింది.
Neostigmine very short acting కదా,
long acting orally acceptable pyridostigmine, అది కాకుండా ఇంకేమైనా డిఫరెన్స్ ఉందా అనేది నా డౌట్ మరి ఎప్పటి నుంచో ఉంది.
Neocause brady.
pyridostigmine మనం అసలు చూడలేదు.
టాబ్లెట్
టాబ్లెట్ వాడతారు కదా సార్.
టాబ్లెట్ pyridostigmine.
అదే లాంగ్ యాక్టింగ్ అది ఒకటే.
ఓకే ఓకే
సార్, మెకానిజం ఆఫ్ యాక్షన్ లో డిఫరెన్స్ ఉందా
సార్? ఎక్సెప్ట్ మెకానిజం ఆఫ్ యాక్షన్ లో అయితే ఏమి డిఫరెన్స్ ఏమి ఉండదు సార్.
అంటే pyridostigmine హాఫ్ లైఫ్ కానీ ఫస్ట్ పాస్ మెటబాలిజం లేకపోవడం వల్ల కానీ అది ఐవి చేయలేకపోతున్నారా, లేకపోతే అందువల్ల ఓరల్ పెడతారా, ఎందుకని?
జనరల్ pyridostigmine ఓరల్ ఫార్మ్స్ ఉంది సార్. యాక్చువల్లీ ఈ డౌట్ నాకు ఎప్పటి నుంచి ఉంది సార్.
అంటే అలా కాదు, కొన్ని మెడిసిన్స్, వన్ స్మాల్ పాయింట్ ఐ వుడ్ లైక్ టు టెల్ యూ, వి ఆల్ గివ్ ప్యాంటసిడ్ కదా ఇంజెక్షన్. అంటే నార్మల్ గా నాకు ముందు తెలియలే, తర్వాత తెలిసింది. ఇప్పుడు మీకు టెన్సిప్ ఉన్నప్పుడు ప్యాంటసిడ్ టాబ్లెట్ క్రష్ చేసి వేస్తారు. ఇప్పుడు మామూలుగా when the people are taking oral tablets, they give pantacid ఇస్తారు కదా టాబ్లెట్. సో అలాగే మనకు పేషెంట్ మన ఐసీలో ఉన్నప్పుడు రైల్ స్ట్రిప్ ఉంది. రైల్ స్ట్రిప్ ఉన్నప్పుడు మనం టాబ్లెట్ మరి రైల్ స్ట్రిప్ లో ఇస్తామా ఇవ్వమా?
క్రష్ చేసి ఇస్తున్నా సార్.
ఇవ్వకూడదు, పనిచేయదు. ఏంటంటే దట్స్ వాట్ ఐఎమ్ టెల్లింగ్. ద డిఫరెన్స్ ఈస్, నాకు ఎగ్జాక్ట్ మెకానిజం కానీ యూ ఆర్ నాట్ సపోజ్ టు గివ్ ప్యాంటసిడ్ త్రూ ద రైల్ స్ట్రిప్. ఇట్ డజంట్ వర్క్. ఇట్ వర్క్ ఓన్లీ ఇఫ్ యు గివ్ ఓరల్లీ. అలాగా దీనికి ఏమైనా ఉందని అడుగుతున్నా. నాకు దానికి తెలుసు, దీనికి తెలియదు.
సార్ ఎందుకు పనిచేయదు సార్?
లేదు మేడం, దట్స్ వాట్ ఐ కేమ్ టు నో.
No, like if any medication, if that's absorbed or function on stomach, like unless the Ryle's tube or in the nasojejunal tube unte, it will bypass the area of absorption, but NG tube unte kuda avada sir. Anyway esophagus lo avadu, but stomach lo ne kada veltundi.
Okay madam, you can go through the literature, otherwise no problem. ఎందుకంటే తెలుస్తుంది it will work. If it is wrong, please let me know, because ఎందుకంటే నేను ఎక్కడో ఒక మీటింగ్ లో మొన్న విన్నాను ఒక few months back. So I was really shocked to listen to that, because after so many years of practice, every time అలాగా మనకు తెలియని ఉండొచ్చు. That's what I'm telling you. So with that class I came to know this point. అందుకే ఇప్పుడు పాయింట్ రైట్ చేసిన, అందుకో అలాంటిది ఏమైనా ఉందా దీనికి అని. సో లెట్ us go ahead again. ఎందుకంటే జస్ట్ లైక్ రైస్ టు బిగిన్ TNT ప్రోగ్రామ్ లో
మీరేదో ఒక వర్డ్ ఏదో ఫస్ట్ పాస్ మెటబాలిజం అన్నారు. సార్ మీరేదో ఒక ముక్క ఏదో ఫస్ట్ పాస్ మెటబాలిజం అనేదో అన్నట్లున్నారు.
అది
Is it-
అది దీనికి అంటే రైట్ రైట్ లో ఫస్ట్ పాస్ మెటీరియల్ వెళ్ళిపోతుంది, ఎందుకంటే ఓవరాల్ అబ్జర్ప్షన్ కాదు.
ఫస్ట్ పాస్ మెటబాలిజం అంటే ఇఫ్ డ్రగ్ హ్యాస్ టు వర్క్ సమ్వేర్ ఎల్స్, బట్ ఇఫ్ ఇట్స్ అబ్సార్బ్డ్ అండ్ గో త్రూ పోర్టల్ సర్క్యులేషన్, లివర్ లో మెటబలైజ్ అయిపోతే ఏరియా ఆఫ్ వర్కింగ్ కి నాట్ ఇనఫ్ అమౌంట్ రీచ్ అవుతుంది, కాబట్టి యూ వోంట్ గెట్ ఇనఫ్ యాక్షన్ అనేది కదా సార్ ఫస్ట్ పాస్ మెటబాలిజం
అవును.
అంటే.
అందుకే అలాంటిది ఏమన్నా దీనికి లేదంటే పైరిడోస్టిక్ దీనికి అలా లేకుండా బాగా ఎక్కువ పనిచేస్తా యాక్షన్ ఏరియాలో దీనికి లేదా, అందుకని వాడు ఇవ్వట్లేదా ఇవి కానీ అడుగుతున్నాను నేను.
నేను అనుకున్నాను బయో అవైలబిలిటీ మేబీ ఈక్వల్, అందుకనే ఓరల్ బయో అవైలబిలిటీ బాగుంటే రెగ్యులర్ యూజర్స్ కి దట్స్ మోర్ ఈజీ అండ్ కన్వీనియంట్ టు టేక్ ఎవ్రీ డే కదా.
దే డిడ్ నాట్ కన్సిడర్ పైరిడోస్టిగ్మా ఫర్ రివర్సల్ అని ఎందుకు అని అడిగేది. దట్స్ వాట్ మేబీ కిరణ్ క్వశ్చన్ ఆర్ నా అండర్స్టాండింగ్ ప్రకారం. When they accepted neostimin, why they did not accept pyridoxine for reversal process, and which is going to be long term effect instead of immediate. ఎందుకంటే షార్ట్ యాక్టింగ్ నియోస్టిమిన్, pyridoxine లాంగ్ యాక్టింగ్ అది ఇంకా బెటర్ కదా.
ఐడోస్టిగ్మిన్ ఆఫ్టర్ రిలాక్సెంట్ రివర్సల్ కి ఇస్తే ఇట్ టేక్స్ టైం కదా సార్, ఇట్ టేక్స్ టైం టు వర్క్. ఒక డోస్ లోనే మీ పని చేయదు కదా వెంటనే.
ఇనిషియేషన్ ఆఫ్ యాక్షన్ లేట్ అనా లేకపోతే డ్యూరేషన్ ఆఫ్ యాక్షన్ లేట్ అనా?
డ్యూరేషన్ యాక్షన్ లాంగ్, బట్ ఇనిషియేషన్ విల్ బి స్లోవర్ కదా. ఇంజెక్షన్ ఫార్మ్ నియోస్టిగ్మిన్ అయితే ఇమీడియట్ గా పనిచేస్తుందని కదా అనుకుంటున్నాను. బట్ ఇఫ్ ఎనీబడి హాస్ ఎనీ మోర్ క్లారిఫికేషన్ చెప్పండి.
అందుకే నాకు తెలియక అడుగుతున్నాను.
కిరణ్, విజయ్,
After
ఇవన్నీ కొంచెం చెక్ చేసి క్లారిఫై చేయండి అందరికి తర్వాత.
అలాగే మేడం.
Neostick short acting, madam. Immediate acting.
That's what I said.
Long acting. But myasthenia gravis లో ఎందుకు యూజ్ చేయట్లేదు అనేది మేడం అంతే డౌట్ అంతే.
Vijay,
మేడం చెప్పండి మేడం.
after cisatracurium need a neostigmin or not?
నాట్ మేడం.
No need, no?
యాక్చువల్లీ సిసోట్రాక్యూరియం ది కూడా డౌట్ ఉంది నాకు, ఎందుకంటే వెన్ వి గివ్ సిసోట్రాక్యూరియం, అట్రాక్యూరియం, we think that they are supposed to be metabolized by cholinesterase, right? అందుకే కదా వేరే అవసరం లేదు, గ్రాడ్యువల్ గా దే విల్ మెటబలైజ్ అండ్ ఆల్సో హాఫ్మన్ డిగ్రేడేషన్ ఉంటుందని we may not need to give reversal. బట్ యాంటీకోలినెస్టర్స్ యూస్ చేస్తున్నాం కదా ఇక్కడ ఈ కండిషన్ లో. సో ఇస్ ఇట్ అడ్వైజబుల్ టు యూస్ సిసోట్రాక్యూరియం? అది డౌట్.
It is given actually in the race book, madam, cisatracurium. So that's why I mentioned cisatracurium.
Ma'am, atracurium he gives allergic reaction, no? That's why we are going for cisatracurium.
Yeah, but whether it is atracurium, cisatracurium, or all non-depolarizing muscle relaxants, there's increased sensitivity and prolonged action, right?
Yes, ma'am.
So we have to be careful. Normal doses kante much less dose ichukovali, and without peripheral nerve stimulator, we shouldn't do the GA actually for these cases.
Yes, ma'am.
Sir, Mohan sir, any other questions, sir? Discussion.
గుడ్ మార్నింగ్. ఏం లేదు కిరణ్, థ్యాంక్ యూ.
Thank you, sir. Thank you, Anuradha madam. Thank you, Rani madam.
Thank you.
Thank you, Kiran.
Thank you,
Vijay.
Kiran. Thank you, madam.
Discussion and a nice case presentation. Thank you. Bye.
Thank you, madam.
Thank you, Ramana Prasad sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, Vijay, and thank you, Kiran.
Thank
Thank
you,
you.
madam. Thank you, madam.
Vijay,
Ah,
nice presentation.
thank you. Okay. Bye bye.
Bye, bye, bye.
అదే ఉన్నాయి అది కనుక్కున్నాడు
ఇవాళ యాపిల్ ఎత్తేద్దాం అయితే పంపిస్తున్నాం యాపిల్ ఇచ్చారు గంజి అమ్మకూడదు క్యారెట్ తెచ్చి క్యారెట్ చూసుకుందాం క్యారెట్ అయితే క్యారెట్ తెస్తానని యాపిల్ కొబ్బరి నీళ్ళు ఫీడ్స్ చూడండి
3 గంటలకేమో ఇది 5 గంటలకి అది కొబ్బరి లేదంటే సూర్యోదయం తప్పించి 5 గంటలకి
అయితే ఎందుకు లేదు కొబ్బరి రేపు తీసుకుందాం ఇవాళ క్యారెట్ ఇస్తే రేపు కొబ్బరి క్యారెట్ దిగుతుందంట కదా
క్యారెట్ కంటిన్యూ చేసాక అది తురుమింగ్ ఉంటుంది కదా మమ్మల్ని ఇది వడబడతారు
క్యారెట్ బీట్రూట్ రెండు కలుపుదాం
సూప్ లోనైతే కలుపుతాం క్యారెట్ ఒకటే కలుపుతున్నాం సూప్ అయితే
సూప్
సూప్ అంటున్నారు సూప్ అయితే క్యారెట్ బీట్రూట్ ఒక లైట్ గా వేసి ఒక టమాటా ఆపేసి ఇంకోటి ఓ బెండకాయ వేసి మిక్సింగ్ చేసి బెండకాయ వేసి బెండకాయ వేసి మళ్ళీ థిక్నెస్ వచ్చింది
క్యారెట్ బీట్రూట్ టమాటా చిక్కుడు చిక్కుడు విత్తనాలు ఉంటాయి పడిపోతాడు అంటే
పెట్టాను
నైట్కి టిఫినే కదండి సాంబారు ఈ ముక్కలు ఎక్కువైపోతాయి ఈ టమాటా తీసేనా పాత ఉంచుతాను రాత్రికి మధ్యాహ్నం కలిపి పెట్టింది గోవా
నాలుగు బయట పెట్టాలి